So this is the either fifth or sixth video that I've done regarding the statement submitted by the Thirlwall lawyers that are representing the families of the infants, and also this Times article that's on the screen now. In this one, we're going to primarily look at child A. I will just briefly mention that I'm not going to cover the case of child F in these videos because the next project is to do a thorough examination of the insulin cases. Child F was one of the insulin infants. All I will say, I'm just going to briefly say something at this point though. The comment made in relation to this is, but lawyers for the family said all the professionals who had given evidence to the inquiry agreed that the baby had extra levels of insulin that were not naturally occurring. So two fundamental problems with this are, firstly, that some of these things stated by the professionals, both at the inquiry and in court, were inaccurate. And secondly, the quality of testing that was utilised in relation to the insulin cases was deeply unsatisfactory. I suppose the third thing to say that I will briefly mention, but I will be discussing in far more depth in future videos, is the strange thing about this is that you're going back years and years to August 2015, years after the fact, when this wasn't flagged at the time. There were no insulin poisonings flagged in August 2015. Both child F and child L survived. They didn't die. They weren't successfully poisoned by insulin. Nothing was considered suspicious or unsatisfactory or incriminating at the time. You're just looking back years and years after the event, and the people that are looking back don't have qualifications to do so. It's essentially Dr. Stephen Breary and Dr. Dowie Evans. I'm really going to go into this in more depth, but it is clear from statements made by Dr. Dowie Evans that he just hasn't got a clue about this. That's not a criticism of him in particular. There's no reason that he would know that much about insulin. The thing is that when other people don't know something about a particular topic or subject, they tend to acknowledge this, whereas Dr. Evans thinks he knows everything about everything and thinks that if he says something, it automatically becomes an authoritative statement. In fact, I would say every single other healthcare professional that I've interviewed, whether in nursing, doctors, whatever it may be, they've all immediately said, this isn't really in my area of expertise, so I either can't comment or I wish to qualify that before I make a statement. Dr. Evans is the only medic I've ever encountered who just says, I'm definitively correct about this, whatever it is. Since he's done it in the case of insulin, even though it becomes quite evident that he really doesn't know the first thing about it. So that's all I'll say about child F for now. This video is primarily going to deal with child A. Letby's defence team claimed child A, a boy, one of twins, who died in June 2015, may have inherited a blood disorder from his mother that left him prone to developing blood clots. The family case is that this ignored evidence given at trial by Professor Sally Kinsey, a consultant haematologist, that confirmed he had not inherited his mother's clotting disorder. This was accepted by the defence at the original trial. So I've already actually dealt with this case and the comments in a previous video. The condition that's referenced here is antiphospholipid syndrome. So I'll go into that again. I may lift the section where I talked about this from the previous video, or I may just go over it again briefly. Again, there are significant testing issues here. Before I do that, I just wanted to, in this video as well, provide some background to child A and discuss some related issues in addition to this claim that Professor Sally Kinsey has contradicted the prosecution case, contradicted the panel's evidence rather. So the first thing to say is that child A was born at 31 weeks, which is not excessively premature, but it is still quite significantly early, a couple of months before a baby should be born. And it's noted here, just in this document, that a baby born at 31 weeks has not had a chance to fully develop their lungs, immune system, sucking reflex, or enough body fat to maintain their body temperature. Now, we're actually very fortunate that over the years, there have been huge breakthroughs in treating premature infants and in neonatal care and in generally in preventing infant mortality. And that means that we now can deal with these infants to a great extent. Even over the approximate decade since the period in which Lucy Letby's alleged crimes, were committed, there's been enormous breakthroughs in that period of time. All of these things, neonatal medicine, etc., have developed. So the prognosis for a child at 31 weeks today is better than it was even in 2015, but it was very much significantly better in 2015 than it had been 10, 20, 30, 40, 50 years previously. If you go back decades, the prognosis for a 34-week infant was very bad. We developed numerous things. There have been numerous medical developments, breakthroughs, innovations in that period of time that means that a 31-week infant has a much better prognosis than has been the case historically. Nonetheless, the survival of such an infant is not a certainty. There are 90,000 to 95,000 neonates born in the UK annually, according to Bliss here, the statistics about neonatal care. And they don't all survive. We see here statistics from 2022 that approximately 1,924, let's say 2,000 to call it a round number, deaths of babies under 28 days of age occurred. The neonatal mortality rate was 2.9 deaths. So essentially, even in 2022, approximately 3% of neonates didn't make it. Back in 2015, this was more like 5%. And the prognosis for an infant that its lungs aren't satisfactorily developed, etc., as we've just discussed, while it is vastly improved, you still see a significant number of these infants that they don't survive, or if they do survive, they're very heavily disabled. And of course, that's very sad, but that's just simply the reality of the situation. There's another thing that I want to talk about is unexplained deaths. So there's a statistic here about the unexplained mortality rate. For male infants, this was well over 3%. So that's not for neonates, that's across the infant population as a whole. Unfortunately, young children they're small, they don't have fully developed organs, all of their vital systems have not developed in the manner of even an adolescent child, let alone an adult. And they are vulnerable, even if they're full size, even if they're full term, even if they're seemingly healthy. Quite a significant number of infants die every year, let alone neonates and premature babies. And many of these deaths are unexplained. So the Office for National Statistics, this is Office for National Statistics data from 2022, there were 171 unexplained deaths of infants, which accounted for 7.3% of all infant deaths. And you see in previous years that the percentage is even higher than this. Sudden infant deaths accounted for 53%. So this is quite a common phenomenon. And it's something that shouldn't be discounted. So this is another thematic report related to sudden and unexpected deaths in infancy, published in December 2023. So I'm going to search for the specific figure here, which is 52%. You can find this here, and this is among neonates. Essentially, 52% of deaths were classified as unexplained. So there was a comment from Dr. Evans that no neonate death, in fact, no infant death, should ever be unexplained, when even 8%, 7 to 8% of perfectly healthy infants that die, no one ever knows why. It's never satisfactorily explained, let alone in these circumstances where you can see 52% are classified as unexplained within this study. And that leads us to the overall picture that we have on the neonatal unit at the Council of Chester. So this is a document from the Thirlwall inquiry, INQ 01088782. So this goes over all of the neonatal deaths at the Council of Chester Hospital in 2015 and 2016. It should firstly be noted that there were 18 deaths it is understood that there were 10 neonatal deaths in 2015 and 8 neonatal deaths in 2016. Now, this was wrongly reported and has been wrongly reported, and still many people believe that there were 17 deaths. The reason for this is one death occurred on the central label suite at the Countess of Chester Hospital. So therefore, the police didn't investigate this death. It's not entirely clear why the police didn't investigate it, perhaps because it's a separate unit from the nurseries where the unexpected deaths occurred. You'd have to ask the police, and Paul Hughes, in his wisdom and huge intellect, would explain to you why they didn't investigate that case. But you can look at these are the 18 infants. We see the infants from the Letby case recognised by letter here, and the so-called non-indictment babies who also died. And if you look at the overall picture of these infants, those that were included in the court case and those that weren't included in the court case are almost interchangeable. But I particularly want to highlight this non-indictment infant that died in January 2016, who was at the conclusion of Postmortem, and it's been cited that there's congenital pneumonia with inflammatory response syndrome. Now, I'd have a very hard time, and I believe even the most qualified medics in the world would have a very hard time separating that from baby D, who was the conclusion at Postmortem was pneumonia with acute lung injury. No one disputes this. It is not contested that child D was suffering significantly, definitely had pneumonia, and all of the evidence points to natural causes, being the death of this infant. But suddenly, when Dr. Evans gets involved, it turns into air embolism, the injection of air into the bloodstream, which is pretty staggering when you look at the full clinical picture related to child D. And I'm sure I will look at this in a future video. I don't know if I'm going to go through all the infants from A to Q one by one. That's possible. I may look at air embolism cases instead, or the injection of air and these related cases, and child D would come up in that. But the point is that if you look at the overall picture on this unit of infants that are acknowledged to have died for congenital reasons, that died for natural reasons, that died for prematurity with sepsis, we've got 9 of 17 of the infants in the court case that have sepsis. And this so-called non-indictment infant dies for issues of prematurity related to sepsis that seemingly disbars this in from being involved in the court case, yet other infants with sepsis, the sepsis is completely disregarded. Here we have prematurity being cited in the case of child P, whereas prematurity has been cited here, but here Dr. Evans has decided, it has to be air down via the nasogastric tube. The point is that, again, we see extreme prematurity here. I've covered child I in a previous video, and we see the whole picture around this with hypoxic ischemic damage of the brain and chronic lung disease. The overall indication is that it's difficult to truly separate, to create a demarcation between the non-indictment infants and those that were involved in the court case. And that many infants can die for these unexplained reasons that we've discussed in these documents, and just simply because neonates are vulnerable, and that they do die in relatively large numbers, in relatively large proportions. We're talking about the time roughly 1 in 20 neonates would die. A good prognosis for a hospital would have been 1 in 30, or 1 in 30 to 35 as it is today. That's just the way it is. These are extremely small infants in some cases. In some cases, they're extremely premature. Even if the initial prognosis for them is good, they can collapse. They can die for unexpected reasons. They can die for unexplained reasons. And this is something that was almost entirely excluded from the court case. And it's relevant in the case of child A because child A is a significantly premature infant with undeveloped lungs. And that's before you get into the conditions on the unit and the other things that we're going to discuss about child A as well. Now, the next thing to note about child A was that he was receiving CPAP treatment, an acronym for continuous positive airway pressure. Here it's mentioned it's a common treatment for obstructive sleep apnea, but of course That would be in adults. In infants, it's a machine that pumps air into a mask that's fitted over their nose or mouth, simply to keep them alive. It's just simply to help with their breathing, ensure that they don't die. That's why they're in a neonatal unit. They can't exist outside of a neonatal unit. We are fortunate that there have been these medical developments that have made it possible to keep more vulnerable infants alive for longer and for them to recover and grow into healthy adults in many cases. And that's incredible. But once an infant is on ventilation, requiring respiratory support, the infant is vulnerable by definition, particularly when it's been born 2 months ahead of its normal birth time. So there's some more information here about CPAP, about how it helps prevent the narrowing or collapse of airways, helps with breathing, and so on and so forth. However, despite having been receiving this CPAP treatment, the breathing rate of child A increased significantly and remained abnormal throughout the 24 hours that preceded the collapse of this infant. This increased respiratory rate for child A indicated likely respiratory distress syndrome. So there's some information on respiratory distress syndrome here. It happens when an infant's lungs are not fully developed and cannot provide enough oxygen, causing breathing difficulties. It usually affects premature babies. I'm just going to make a reference to this here. This condition usually occurs when the baby's lungs are not producing enough surfactant. We'll be returning to that in a second. It's a very important substance that is critical in this case. Surfactant, made up of proteins and fats, helps keep the lungs inflated and prevents them from collapsing. A baby normally begins producing surfactant sometimes between 24 and 28 weeks of pregnancy. Most babies produce enough to breathe normally by week 34. So as you can see, let's say we don't know the situation with child A, but let's say it become late. The production of surfactant had increased late in pregnancy, say week 28, and then it's supposed to go up to week 34. Most babies produce enough by that time, maybe some don't. This baby's born at the 31st week, so as is rightly noticed here, if your baby's born prematurely, they may not have enough surfactant in their lungs. Now, interestingly, today, my researcher made me aware of this case of Patrick Bouvier Kennedy. I didn't know anything about this at all, but this was a son of John F. and Jacqueline Kennedy, who was born prematurely at 34 and a half weeks gestation in 1963. Patrick tragically died of respiratory distress syndrome just 39 hours after birth, despite receiving the best medical care available at the time. His death at 34 and a half weeks gestation and his struggle with respiratory distress syndrome highlighted the challenges faced by premature infants and spurred advancements in newborn care. So the outlook for premature infants since 1963 has increased significantly, but it's still possible for a premature infant. This infant's significantly more premature than Patrick Bouvier Kennedy. It must be said that 1963 was a pretty terrible year for the Kennedy family for one reason or another. But regardless of that, the outlook is better for a 34-week infant today, and it's significantly better for a 31-week infant. But they can still have issues with surfactant. They can still have issues with breathing, and the evidence indicates that this infant was struggling with respiratory distress syndrome, and that can still cause problems today. Just a simple overview here, that neonates can still die from respiratory distress syndrome. It's a serious condition that can cause significant complications, especially in premature infants, including death. Advancements in treatments such as the surfactant therapy that we just discussed and ventilatory support have dramatically improved the prognosis, but they haven't eliminated it completely. Surfactant therapy was a major breakthrough in neonatal medicine, significantly improving the survival and outcomes of premature infants with respiratory distress syndrome, effectively replacing the missing surfactant in their lungs via therapy, reducing the severity of this symptom. But if things are not dealt with correctly, then it can still be very problematical. One of the things that we know about child A was that he was suffering with an increased lactate level, which is in itself associated with a higher likelihood of morbidity and mortality. We can see there's some information here on increased lactate level. This can be a clinically significant issue that may indicate underlying issues related to oxygenation, metabolism, or circulation. And again, we see why lactate can be elevated in a premature baby, and it's several conditions that we see over and over again in these infants. Firstly, it's poor oxygen delivery, which is very indicative of respiratory syndrome, as you might imagine. Premature babies often have immature lungs. We know that a 31-week infant will have immature lungs, which can lead to low oxygen levels. And then we see here sepsis and infection, poor perfusion and shock due to conditions such as sepsis. Of course, we've seen all these infants over and over again suffering with sepsis, in common with the infants that weren't included in the court case because they were deemed to have passed away due to sepsis. So they became what was described as non-indictment infants. But we see the infants included in the court case suffering with sepsis, including this infant, due to their underdeveloped immune systems. And then there can be metabolic and congenital conditions as well. But a rising lactate level is problematical. However, it can be dealt with if it's evaluated correctly, if oxygenation occurs correctly, if the vital signs are monitored correctly, if the signs of infection are investigated correctly, if these metabolic issues and cardiac problems are dealt with correctly. But as we know on this unit, there were constant indications of failure to monitor things, failing to react to things properly, failing to do ventilation properly, failing to hydrate correctly. And we see that reflected again in the case of child A, with this infant going without fluids, IV fluids, for at least 4 hours, receiving just 2 millilitres of breast milk during this period while being kept under a heat lamp during the period that it was attempting to access IV lines. Now, the reason it's being kept, the infant's being kept under a heat lamp is to prevent hypothermia, but this extended period of time under heat and without fluids increases this risk of fluid deficit, leading to electrolyte disturbances that can affect the brain and heart. This is already in a very vulnerable infant that is struggling. It's struggling to oxygenate itself. He's struggling to breathe. And for an infant of this size in gestation, they should not spend a significant amount of time without fluid and beneath a heat lamp. So I've asked a simple question about this. Infants of 31 weeks gestation should not spend significant periods without fluid and beneath a heat lamp. Is this true? Yes, that's true. It's because of fluid balance and hydration issues. Preterm infants have immature skin and kidneys, making them very prone to dehydration. Heat regulation is problematic. As I mentioned, heat lamps are used to prevent hypothermia, but prolonged exposure without adequate hydration or temperature monitoring can lead to dehydration and overheating. Incubators are considered better for longer period of care, so best practice would be warm environment, strict fluid management, and continuous monitoring of temperature, weight, etc. As we see, this unit failed on these issues repeatedly, and that there were serious problems with child A. And then there were problems with chest compressions causing free air to circulate in the anatomy of child A, which eventually led to skin discolorations and a rash being noted in the case of this child. Now, this was turned around by Dowie Evans into being an indication of embolism, but such discoloration and rashes can much more likely be indicative of a cardiorespiratory event. They're essentially a sign of blood seeping away from the surface of the skin to the organs. So I've discussed this here. Skin discoloration and rash was noted in the child A. This can be indicative of a cardiorespiratory event, a sign of blood seeping away from the surface of the skin to the organs. Is this true or false? True. Skin discoloration and rash, particularly when involving pallor, paleness, cyanosis, bluish tint, or mottling, all of which have been observed, can indeed be indicative of a cardiorespiratory event in a child. This is because such events, the body may redirect blood flow away from the skin and towards vital organs, such as the heart and the brain, which can result in visible changes in skin colour. And because the staff at the Cancer Chester were relatively inexperienced and less trained in intensive care patients, it seems likely that they were simply unfamiliar with such skin patterns, hence the reports of never having seen them previously. So that's a very strong indication of the clinical picture associated with child A, and it helps to explain some of the phenomena and some of the problems that this infant experienced. However, it's not the whole clinical picture, because there were several problems made with this infant that magnified things further still and almost certainly led to the ultimate demise of the child. So another issue with child A was that the long line of the infant was inserted in a way that was too deep, and it was considered too deep both by the doctor that placed it and the consulting radiologist, but it was never corrected. The long line essentially, as mentioned here, this inserted catheter. So that's the question of whether this could cause significant problems to an infant, premature infant with respiratory problems. Naturally, it can be problematical. The complications include arrhythmias, cardiac tamponade, which obviously I don't know exactly, fluid in the pericardial sac, which can be fatal, perforation of cardiac structures, respiratory compromise. The last thing this infant needs is respiratory compromise, clearly, and other issues as well. Signs of trouble in such an infant would be worsening respiratory distress. We see this in this infant. Bradycardia desaturations. We see this in this infant. Nuanced arrhythmias. I can't say whether or not that occurred off the top of my head, but there were significant symptoms that indicate that this was a problem, which of course it is known to be a problem. This is hardly contentious in any way. So the bizarre thing about it is, and this is the Court of Appeal verdict, that everything in this case points to suboptimal care. And we're going to go over this in some further detail yet. But despite this, Dr. Evans in court said something completely different. It should be noted that suboptimal care on the unit was conceded in court, even by the prosecution in other cases. And there were serious questions about the stability of this infant, which meant that this infant needed very good care. Hence the fact, as we're going to see shortly, he was transferred out to a level 3 unit on several occasions. These points were raised by Professor Michael Hall when he spoke with Judith Morris and Jonathan Coffey for the book that they've written. And yet, despite this, Dr. Evans has claimed that child A was stable and doing really well. And then we see this repeated here in this paragraph 52. Dr. Evans said he had prepared a number of reports about baby A. Of course, he couldn't possibly just prepared one report because he's changing his opinion constantly. But that he had not known about the reported skin discoloration when he first made the diagnosis of air embolus. So we've discussed this in a previous video, but he's diagnosed air embolus before even knowing about skin discoloration, but that's the only diagnostic criterion. There's no possible other conceivable reason to suspect an air embolus here, and we're going to see, again, further indication of that in due course. But he had not known about the reported skin discoloration when he first made the diagnosis of air embolus, as the witness statements had not been sent to him. He made a diagnosis on the baby that baby A had collapsed suddenly when in a stable condition. There was no evidence of infection or lack of oxygen, and the modest fluid loss which had resulted from the delay in putting the line up had not been sufficient to cause the sudden onset, unexpected collapse. The sudden collapse of a baby, even in the neonatal unit, was unusual. Typically, there would be warning signs, and babies do not go from a normal heart rate and normal oxygen saturation without some warning signs. When he prepared his first report, the only other condemned for the collapse was the administration of noxious substance. but he accepted his evidence was nothing to support that diagnosis. I mean, this just seems like total crap, of course. He was therefore left with the embolus as the explanation. This is another indication of a diagnosis of exclusion, which we'll discuss previously. We'll get into that in more depth when I go through the embolism cases. If the witness's accounts were reliable, then the pattern of discoloration and flitting movements was what you get in an ambulance. I mean, this is just absolute shit science. It's a shit diagnosis from someone that clearly wouldn't be very good at his job medically and hasn't, at this point in time, hasn't worked in a hospital for nearly 20 years. It's just an unbelievable opinion that is just so flawed that it's no wonder that medical professionals are responding so strongly to this case. But to say that this infant had collapsed suddenly when in a stable condition, there was no indication of anything being wrong, there's no evidence of infection or lack of oxygen, is just absolutely ridiculous. As I mentioned, I should move to this image. This infant was transferred several times to a level 3 tertiary care unit. That's because it needed... This infant was really, really struggling and wouldn't have survived. It didn't survive anyway, but it wouldn't have survived on the Council of Chester because this unit was patently unable to deal with infants requiring the highest level of care with advanced medical interventions. That's why, as we saw in the previous case of child G, the child was not allowed to be born on this unit because it wasn't able to care for it. And many of these infants needed level 3 care and didn't receive it. And this was an acknowledgement that this infant needed level 3 care. That's why it was transferred out. But there shouldn't be this situation where an infant is being transferred back and forth, back and forth. I mean, this unit wasn't even up to level 2 status because it was downgraded back to infants that need minimal medical or nursing intervention. Hence the fact that when that happened, they stopped having problems. Not because Lucy Letby was removed from the unit, because they weren't dealing with these infants anymore. These infants that were deemed level 2 but probably should have been level 3. So another problem that is again not mentioned by Dr. Evans was not only was this child transferred to a level 3 unit, but there was also problems with the placement of an umbilical venous catheter. There were multiple attempts to do this, in fact 7 attempts, and research indicates that every attempt to do this heightens the risk of collapse and illness. So we can see here that multiple attempts at umbilical venous catheter placement can increase the risk of complications, including vascular collapse, infection, and other serious issues. And then there's some explanation of why it increases infection risk, why it increases the risk of vascular injury and collapse, why it increases procedure time, technical complications, and stress and instability. It is something that you don't want to happen once, let alone 7 times. If it happens 7 times, then you're multiplying the risk of all these problems over and over again. This child crashed 15 to 20 minutes after having fluids being applied through a UVC line that they had not satisfactorily established was patent. So this term patent refers to the degree of openness of the tube, but they just decided they'd use it anyway. There's a catalogue of failings on this unit. Another one is that child A couldn't have his long line pulled back because I'll move on to the papers in a second. It couldn't have the long line pulled back because the qualified staff were busy with another child. Lots of neonatal experts that I've spoken with pointed to prolonged dehydration, this risk of overheating under a heat lamp. 7 attempts to place a long line that was coming out repeatedly. And I was told the likely explanation for this is they failed to prime the lines correctly, so they need to be primed with fluids. Speaking to these neonatal nurses, and they say you just simply don't do something like this over and over again. It's very poor practice, and you're just escalating the risk for this already vulnerable infant that's already been transferred out of the unit, that's already receiving ventilation, that's already struggling with its breathing, that is already clearly vulnerable, that is already showing signs of respiratory distress. And then there's multiple placements of this UVC line, which, as we see here, heightens the risk of collapse and illness. So multiple attempts at an umbilical venous catheter placement are associated with an increased risk of complications, including mechanical injuries, inflections, and potentially life-threatening events. So it's hardly surprising this infant experienced problems. There's a paper here. This is umbilical venous catheter complications in newborns, a 6-year single centre experience, and its conclusion is that although UVC is a common and easy vascular access, this process is not without complications. So really, you might ask the question immediately of why it took 7 attempts when it's described here as an easy vascular process. This would suggest severe failings on this unit. But it says here the UVC may be inappropriately positioned because the catheter is inserted by the paediatrician without imaging guidance and may occasionally be associated with complications. But they're going to be complications if it's done wrongly 7 times. Inappropriate positioning of the catheter may be observed during the follow-up and maintained care. Therefore, newborns, particularly in premature and very low birth weight newborn, should be followed in terms of catheter complications during insertion, following and just after removing the catheter. Now, the incredible thing about all of this that I've discussed is that it was all known at the time. This is not something the panel has had to discover. It is not something that isn't documented. It is documented here in this document INQ0001944 underscore 01 underscore 03 which is a pan-Cheshire CDOP palm seat analysis pro forma, which is used to acknowledge the issues and record the issues and document the issues related to this child when it sadly passed away on the 8th of June 2016. The child weighed just over 1.5 kilograms at birth. There was good tone, no heart rate, and only minimal respiratory efforts. He was given inflation breast, but there was minimal or no chest wall movements, but heartbeats were audible soon after. He was transferred to the neonatal unit and put in an incubator on CPAP. Peripheral IV access was gained. At 2 to 3 hours after birth, his condition was fairly stable on CPAP. An umbilical catheter was inserted under sterile condition. X-ray review showed that UVC was not ideally placed. UC was recited. Review again showed it to be not ideal. The plan was to remove the UVC and a long line to be inserted. However, apparently UVC was left in situ and a long line was inserted. X-ray review showed that the long line had crossed the midline and possibly the tip to be in RT subclavian and superior vena cava. The line was supposed to be pulled back later. The patient went into apnea. Bagging was started immediately. There was good chest movement seen, but saturations were poor. It was thought to be related to long line, so long line was removed and help was called. Intubation was attempted, blood clots were noted in the tube. The heart rate dropped, chest compressions were started, full resuscitation was attempted with no significant response, and were discontinued when the child sadly died. Now, how that becomes, where's the comment here from Dr. Evans? How that becomes the baby suddenly collapsed when in a stable condition, I have no idea. I mean, frankly, that's an extraordinary piece of diagnosis. I mean, this indicates a catalogue of issues, very serious problems, procedures being carried out incorrectly that render the baby extremely vulnerable. It's an infant that's already got massive problems, that's been transferred to a tertiary level 3 unit, that is struggling to breathe, that's got respiratory problems. And it should be emphasised, it's on CPAP. The infant is on CPAP because he cannot breathe properly. And yet they're moving things in and out, in and out, in and out, reinserting things. It's hardly surprising. It's hardly surprising they tried full resuscitation and the child sadly died. That could be considered no surprise. And, you know, I even consider it slightly odd. Clearly, I'm not medically qualified, and you'd have to get someone in who's a medical expert. But I'm not quite sure why there was this unascertained conclusion at post-mortem. But to then conclude that this infant died due to air embolism and the injection of air into the bloodstream is extraordinary. And it's particularly extraordinary because Dr. Horden and Dr. McPartland conducted the pathology post-mortem of this infant, and they concluded that although child's age death remained unascertained, it was noted that there was no evidence of air embolism. So you have all of these things that I've discussed so far in the video. You have no evidence of air embolism, but when Dr. Evans gets his hands on the case notes, he suddenly concludes that it's an air embolism due to the deliberate injection of air. Now, we're going to go over the information to this in more depth shortly, But this is very significant background to this extremely unwell infant that was clearly really struggling and then was not treated and cared for in the way that needed to occur from this infant that needed level 3 care. Clearly, it needed level 3 care because he was transferred out to another unit on several occasions. And it's very, very sad that the hospital failed this child. And mistakes can happen, and I don't think we should be too hard on them because I think they were all trying their best, but it was not a competent unit. It was not a unit that should have been dealing with these infants. It was a unit that was understaffed, underskilled, inexperienced, that perhaps unsurprisingly, despite the fact that I'm sure all the staff were trying their best, they made several mistakes. And I don't know if Child A is the best example of this. It's certainly one of the best examples, but I'd say it probably is the example in which the medical staff just completely failed this child and the child passed away due to its vulnerable condition combined with these quite clear medical errors. So the work of Dr. Horden and Dr. McPartland indicates that there's no embolism. And this is another autopsy and postmortem report from Dr. Joan McPartland from January 2017. It was actually submitted on the 25th of January 2017. There's already been a pathology report from Dr. Horden. Then this is Dr. McPartland examining the deaths of Child A, Child I, Child O, and Child P. Now, ironically, we've dealt with 3 of those children in these initial videos. We've already dealt with Child I, we've already dealt with Child O, we're now dealing with Child A. Child P we'll deal with in the future because it wasn't raised by the Thirlwall family lawyers. So in this autopsy report by Dr. McPartland, she says this very clear statement that should be pretty easy to understand. A very small embolism might not be detectable at autopsy, but then would not be expected to lead to death. So what she's saying there is, I haven't seen an air embolism. I would see an air embolism. I could miss a very smaller embolism, but it's not going to kill an infant. That's the whole point. And we also see here Dr. McPartland going over some of the issues that we discussed already. The baby's pre-terminal collapse occurs soon after long line insertion. However, at autopsy there was no evidence of air embolism, damage to vessels, bleeding, or hemopericardium to suggest that the line insertion had directly led to the deterioration and death. They're talking a lot about line insertion and various things. Now, another thing to know here is major autopsy findings were of crossed pulmonary arteries macroscopically and pulmonary hemorrhage on histology. So I knew the answer to this question already. It's obvious. People know, I'm sure people watching this video, you're intelligent people, you know what the pulmonary arteries are. It's the major arteries coming from the heart. For those to become crossed, there has to be something pretty significant happen. So air embolism is obviously not going to cause that. Could an air embolism cause crossed pulmonary arteries? And air embolism and crossed pulmonary arteries are 2 very different things, and one doesn't typically cause the other, and obviously there's an explanation of that. It's pretty obvious, really. So this is a coroner's report of this coroner, Nicholas Reinberg, who's working at Council Chester at the time, and he's having a discussion with an anonymised doctor called Dr. S, and they're having a discussion about air embolism. So Dr. S confirmed that there have been cases of respiratory arrest followed by cardiac arrest where an air embolism will be present, and normally one would see froth when the heart was opened up where the blood had mixed with oxygen. However, this had not happened in this case, and there was also nothing in the brain to suggest any particular problems. So I'm mentioning this because frothy blood in the ventricle, particularly the right ventricle, the ventricle being the 2 compartments of the heart, is a classic sign of venous air embolism. This occurs when air enters the venous circulation, travels to the heart, and mixes with the blood, creating a frothy appearance. Now, I'm going to go into this in much more detail in future videos, so I won't give a full explanation of this at this time, but essentially the point is that if there'd been an air embolism, frothy blood should have been present, and as you see, there's a doctor and a coroner, and it's previously been examined by 2 different pathologists, and none of these 4 people have identified frothy blood, and they're citing frothy blood as being important, and it simply isn't present, indicating that there's no air embolism. Aside from all the other indications I've already given that there's no air embolism. So I just wanted to mention as well, we discussed earlier pneumonia in the case of child D, and there's an article here by the great Ciaran Apton in the Daily Telegraph from November 2024, where she discusses the pathologist identifying clear-cut pneumonia in the case of child D, and no evidence of air embolism. This is Dr. Joe McPartland, who we just mentioned, the pathologist at Old Eye Hospital, said there's clear-cut pneumonia in the lungs, no evidence of the froth that is often the sign of air embolism, and there's just nothing pointing to this diagnosis being remotely correct. So in this account from the Thirlwall inquiry, this is from the 22nd of October 2024, we hear this record of Dr. Stephen Breary stating, "I would be very surprised if child D's death is linked in any way to the previous recent deaths of child A and child C." Unfortunately, then became obsessed with them being linked. But anyway, it was very early on established that there's no reason to believe that these deaths should be linked in any way. And then from another Thirlwall document, we have Dr. Andrew Brunton saying, "I did not make any links to the coroner in my statement regarding deaths of child C and D and the collapse of child B, as it had never been suggested that these incidents could be linked in any way. There's no reason to believe they should be linked, as the pathology of them and their clinical signs, the symptoms, etc., are all completely different." However, in the Court of Appeal judgment, this is paragraph 58, we see Dr. Evans noting that the pattern of collapse was similar in both cases of baby A and B. If the pattern is the same, it's more than likely that the cause is the same. And we saw this throughout the court case, but particularly in the early stages, particularly with children A to D, that they would just transfer the diagnosis on from one child to another. And this previously occurred in the Lucia de Bert case, due to this theory that's described as a chain link. Let me just find it in here. Here we go. So, in 2 cases, the court concluded that there was proof that de Bert had poisoned the patients. Concerning the other cases, the judges considered that they could not be explained medically and must have been caused by de Bert, who was present on all of those occasions. Sounds familiar, doesn't it? The idea that only weaker evidence was needed for the subsequent murders after 2 had been proven beyond reasonable doubt, dubbed chain link proof by the prosecution, was accepted by the court. We saw exactly the same thing occur in this case, which has led to a very unsafe prosecution. And this is despite the fact that medical evidence doesn't point to the fact that these cases were the same or even linked in any way, as numerous people have just stated. So when you put the full picture of child A together, this is a vulnerable infant. There have been medical mistakes. What was communicated in court is simply factually inaccurate. And we know that the diagnosis that was made in court and on which Lucy Letby is convicted is just not supported evidentially. But I'm going to summarise this everything that we've discussed now. So to summarise this video, child A was born at 31 weeks, increasing the risk of complications and mortality immediately. The prognosis for premature infants has improved, but many still die for what are often unexplained reasons. Child A struggled to breathe adequately from birth and required CPAP ventilation support. There is overwhelming evidence that child A was suffering with respiratory distress syndrome. Child A also had an increased lactate level, again associated with an increased risk of mortality. Child A had to be repeatedly transferred to a level 3 unit due to his vulnerability and chronic health problems. There are a catalogue of failings on the unit in relation to child A, none of which are contested. These include: child A desperately needed surfactant treatment, but never received this. Child A went 4 hours without IV fluids, receiving just 2 millilitres of breast milk. Child A was placed under a heat lamp for an extended period, increasing the risk of dehydration and electrolyte disturbances. The long line of child A was inserted too deeply, but this was never corrected. Numerous mistakes were made with line placement, and one catheter was inserted no less than 7 times, risking a catalogue of ailments and problems. Postmortem examination of child A did not uncover any evidence of air embolism. This included no presence of frothy blood, considered a classic sign of venous air embolism. Skin discoloration observed in child A points to a cardiorespiratory event. Somehow, despite all of this, the pathology reports and all known information regarding child A were inexplicably overturned by Dr. Dowie Evans. So just return to this point as well. Although premature infants can pass away for unexplained reasons, I think that in this case there were many compelling reasons why this infant was experiencing difficulties, why it deteriorated and collapsed, and why he ultimately didn't survive. I mean, I'm fairly surprised that the pathology report recorded an unascertained verdict of death, even though obviously there's no indication of air embolism. That was almost entirely ruled out by the pathology reports, and there were 2 reports done on this infant. And it's incredible that this was allowed to be overturned and then passed into the court process and then asserted in court as being scientifically valid. I mean, it has no scientific merit whatsoever, it has no medical validity, just total rubbish. And this is why the defence witness, Professor Michael Hall, has been so critical of this case, and now, of course, we see the panel being very critical of it as well. So I'm going to split this infant, child A, into 2 separate videos. I've also dealt briefly with child F in this video, but this is mainly focused on child A. I did notice that the last video was particularly long, and I'd like to keep these videos to 1 hour, or certainly less. I mean, that one was nearly 2.5 hours. I really appreciate the fact that people have supported me, and the videos have received a lot more views than I expected. And I know people have watched to the end because, firstly, you get the YouTube statistics, and secondly, people have made comments and asked questions that relate to things that are well into the videos. So I'm very appreciative of that. But I don't ideally want to make loads of 2.5 hour videos. I'd like to make them between 1 and 2 hours, or less than an hour, whatever is possible. So I don't know how long the second part of this video is going to go on for. So I'm going to make this a 2-part video. This video deals with the background of child A, the pathology reports, the fact that they should never have been overturned, the fact that they should never have been diagnosed as air embolism, because there is quite explicit evidence that it wasn't an air embolism. In the next video, we're going to go on to look at the specific assertions of the panel related to antiphospholipid syndrome and some respected issues. But as always, thank you for the support, and if you have any queries, comments, corrections, or anything else that you'd like to share, then please do so.